Good morning to everyone. My case is about cytomegalovirus associated anterior uveitis. I am Araks Davtyan from Armenia, Yerevan. Cytomegaloviruses belongs to herpes viridae family. Human are natural hosts. It is common infection, usually initial infection without any clinical symptoms. And by US statistics, people will have infection by the age of 40, the half of people, and 19% will be infected by the age of 80. It kept in mononuclear cells in latent form. Ocular manifestation depends either patient is immunocompetent or immunocompromised. In immunocompetent patient, we can see conjunctivitis, endotelitis, anterior uveitis. In immunocompromised patient, it is almost always CMV associated retinitis. Now the case, 27-year-old male referred for evaluation with a history of anterior uveitis for 2 months in the right eye. He was under steroids drops with HLA-B27 negative testing, and rheumatological evaluation was done without any significant findings. Ophthalmologic examination revealed visual acuity was 1.0 in both eyes. IOP elevated in right eye for 24 and in the left eye 16. Patient presented with mild conjunctival injection, mild non-granulomatous keratotic anterior chamber flare was +1, self +1, 2 +2. Examination of vitreous and fundus were unremarkable. Here we can see increased IOP. It is can be due to steroids drop, as well as we always keep in mind the anterior uveitis associated with increased IOP. Those are herpetic, anterior uveitis, Posner-Schlossman syndrome, syphilis, toxoplasmosis, and sarcoidosis. Topical steroids started every 2 hours with antihypertensive drops, as well as cycloplegics. 1 week later, patient comes back with decreased IOP and anterior chamber rare cells. We started taper the steroids. Then 3 weeks later, patient came with recurrence, and now we have elevated IOP and mydriasis and recurrence of inflammation in anterior chamber. We always should to remember that increased IOP with mydriasis in anterior uveitis has almost always viral origin. So you can see here dilated pupil, mild iris atrophy, as well as keratotic precipitates. Anterior chamber paracentesis was done, and we have positive results to CMV retinitis. I would like to highlight that cone-shaped keratotic precipitates are very typical for CMV retinitis, and here you see the picture taken from internet. This one is our patient. There is some mild coin-shaped precipitate. That's why we did the paracentesis, and it came positive to cytomegalovirus. Treatment was initiated with oral ganciclovir 900 milligram twice daily for 3 weeks, topical steroids, and 3 weeks after treatment, IOP it decreased to 16, anterior chamber flare and cells were resolved, and there was just mild remained keratotic precipitates. Steroid was tapered and stopped within 3 weeks, and we kept valganciclovir for prophylaxis dose. And after 2 months of treatment, there is dilated pupil without any inflammation. 6 months later, we see that the mydriasis was resolved. No recurrences so far. Just 1-2 precipitate remained after the treatment. So, thank you for your attention.